Good evening all. So this is the last topic of this particular session, UBA-TLF, what, how and when. So it's basically endoscopic assisted interbody fusion. It's more, somewhere in between PLIF and TLIF, so not a classical TLIF surgery. Most of the points we've already seen, so we just skip through these. These are the markings that we do. We mark the midline, we mark the median pedicular line, we mark the midpoint of the transverse processor. So these three lines are your guides. How we do that on the skin? So this is the incision. So that's midline, that's median pedicular line, that's midpoint of the transverse process. So the third line is what we don't want to cross. So the second line to third line is your guide. You start somewhere between the first and the second line. Depending on what size of cage you are putting, you can extend, but the third line you should not cross. Don't want to go too lateral. So we'll just directly jump into the video. So this is L4-5 degenerative listhesis. And yeah, you've already seen how it works, the initial soft tissue clearance and everything. The major difference between discectomy, decompression and TLIF is here we want to preserve as much as bone as possible. So I only burr that much of bone which will allow my Kerrison punches to go inside and so that I can collect everything. So the triangulation point, the meeting point is same, but the extension laterally is over the facet. Here we don't want to preserve the facet, we want to do a facetectomy. So I'll be burning everything that is there on the lateral aspect, on the top of the facet capsule and epidural vessels and everything. I'll expose the inferior articular process completely right from the base to the tip. I'll start cutting it from the base and move gradually cranially. It's a very small hole, 1.52 centimeters. I can't take the facet out in one go and then struggle with that bone graft not coming out. So we have to chip it into smaller pieces. You can actually see on the lateral aspect of the facet. And then the flava is free, both from the cranial as well as the lateral side. Only the origin part of the flava is remaining. You can just take it out. You can take big bites and you can just go through it. And the epidural space will be exposed. So that is the traversing nerve root in front of you. After retraction, that is the disc, and the rest everything is same. So through the working portal, you can have two instruments going in simultaneously. So it's a normal root retractor which my assistant is holding on the opposite side, and I'm doing all the annular work. So annulotomy, putting in your shavers, rimming out, taking out the disc, rimming the end plates, going inside, taking out the cartilage, cage insertion, everything that you would do otherwise in a mini TLIF or an open TLIF surgery, just under endoscopic visualization. So you do rimming, you have already secured most of the grafts. So you go inside, take out the disc. That's how beautiful the end plates look from the inside. You retract, you put in the cage under direct visualization. We have a special retractor which will make sure that under C-arm you will be able to see that the traversing nerve root is protected, even though when a big cage is going inside, you're not able to see the traversing nerve root. There's a special retractor that will make sure that the traversing nerve root will be protected all throughout. The cage goes inside, sits like that. You can see it is flush with the lower and the upper end plates, and you can end the procedure by utilizing the same two incisions for percutaneous screw fixation on your side as well as on the opposite side, and that's it. This is a preoperative and postoperative MRI. The major difference that I want to highlight here is look at the paraspinal muscles in the postoperative MRI. There's barely any white shadow or atrophy. You see any open or micro tubular postoperative MRI, you see a big white patch there. Most of the paraspinal muscles are stripped off, so that's a major difference there. This is just one more case wherein it was a attempted intertransverse fusion previously, and she had it failed, and she had persistent listhesis with radicular symptoms. So normal, on your left side you can see that is the normal triangulation, but in a revision case where you want to do fusion, your triangulation point will change. So you land on the nearest possible bony landmark there. So that will be your pass. You dock there, you dilate, you triangulate, and you go inside. And just like you would do in any other open surgery, you find the bony, your nearest bony landmark. You'll start exposing that. So that is your tip of inferior articular process. Medially is all the scar tissue. And the target here was just to stabilize. Decompression was already done previously. So rest of the things remain the same. You use osteotomes. That is the dissection of the scar tissue on the medial aspect. So that is the medial part of the inferior articular process. A hooked probe is used here. Same RF console with a different kind of a probe because the scar tissue is slightly troublesome from the previous surgery. And small 1 or 2 millimeter Kerrison punches to expose the traversing nerve root there. The rest everything is same. You will retract the traversing nerve root, and rest we have already seen. You punch in the bone graft inside. You can actually go inside the disc, see how much of bone graft is stuffed inside, put some Abgel so that the bone graft doesn't float out, put in a cage that goes directly under vision. You can actually see the retractor holding the traversing nerve root there, and end up with a percutaneous screw fixation on either sides. So that is the original scar tissue that was for the bone graft, and these three are the incisions that are taken for UB TLIF. Even if it is a case of multi-level listhesis, so two-level TLIF can be done with a similar approach. I'll just stop here so that we can save some time. Thank you, sir.